The second lecture will be about laryngeal cancer staging and cartilage invasion. It will be given by Dr. Laurie Loevner. She's a professor of radiology and appointment in Department of Neurosurgery, Head and Neck Surgery, Ophthalmology at University of Pennsylvania, and Chief Division of Neuroradiology at University of Pennsylvania Health System. She served as chair of Head and Neck Neuro-Oncology Committee of American College of Radiology Image Network. She graduated from Brand University and followed by University of Pennsylvania School of Medicine. Her radiology residency at University of Michigan and fellowship in neuroradiology at University of Pennsylvania. Dr. Loevner has served on a numerous committees of multiple national societies, including International Society of Magnetic Resonance in Medicine, American College of Radiology, Radiology Society of North America. She's co-chair of Foundation of American Society of Neuroradiology. Dr. Loevner has 170 peer-reviewed publications, dozens of chapters, 6 textbooks. She got annual recognition, the Best Doctor in America and Top Doctor in Philadelphia magazine since 2002. She's founding member of Academy of Master and Clinician in Pennsylvania and now co-chair.
Okay, well, thank you. Welcome, everybody. Thank you for the invitation to the Scientific Committee for this wonderful invitation to participate in this meeting. I'm deeply appreciative and glad to share the podium with so many wonderful colleagues nationally and internationally, so I'm glad to be here. Today, I'm going to be talking about laryngeal cancer. We're going to specifically look at patterns of tumor spread and cartilage invasion. And what we're going to do, I'm going to go back and review just a little bit of the anatomy as it pertains to surgical management, surgical landmarks that make people a total laryngectomy, a vertical laryngectomy. So we'll re-emphasize some of that anatomy briefly. And then we're going to spend a lot of time analyzing images to map the extent of laryngeal cancer. We're going to be looking at submucosal spread into the preepiglottic space and the paraglottic space. We're going to look at transglottic spread along the mucosal surface or the paraglottic gutter from one part of the larynx to the other, from the supraglottis to the glottis to the subglottis, the supraglottis to the glottis to the subglottis, the glottis to the supraglottis. But there's an important pathway to remember. We're going to look at extralaryngeal spread, and then we're going to be talking about cartilage invasion. So just briefly, the larynx. Now, we've just heard a great talk on the supraglottis, the glottis, and the subglottis, but I want to emphasize that each of these is treated individually and separately by the surgeon and the radiation therapist. So you might think of it as the kidney, the liver, and the spleens. They really do have different prognoses, survival rates, and management paradigms. So it is important to be very specific about what you're looking at. Again, we heard about the cartilaginous backbone. We have our epiglottis that protects the airway, the arytenoids that support the true vocal cords, the thyroid cartilage, which supports the larynx, and the cricoid cartilage, which is the only cartilage necessary to maintain airway patency. Now, again, it's very important to emphasize this anatomy on this sagittal reconstruction. We see the hyoid bone, and then we have the free edge or the super edge, the suprahyoid epiglottis, and we have that hyoepiglottic ligament that we heard about. But this is a very important ligament. It prevents spread of suprahyoid tumors and oropharyngeal tumors from the vallecula and from the base of the tongue into the preepiglottic space. Once you get into the preepiglottic space, not only do you have at least a T3 tumor and at least a supraglottic laryngectomy, but there's a rich crisscrossing lymphatic system, so the incidence of bilateral nodal metastases doubles when the preepiglottic space is invaded by neoplasm. We have the infrahyoid or the petiole of the epiglottis, right, and this is a conduit right into the preepiglottic space because there is no resilient ligament there. Our thyroid cartilage, and deep in the confines, our arytenoid, our corniculate cartilage, the vocal process that gives off the vocal ligament that inserts on the inner lamina of the thyroid cartilage, the cricothyroid membrane through which the recurrent laryngeal nerve penetrates to innervate the larynx. And then we have our cricoid cartilage, and it's, remember, the back of the cartilage is 2 to 3 times taller than the front of the cartilage, and just below that we have the trachea, or the beginning of the lower aerodigestive tract. So again, subsites are important when we look at staging of supraglottic cancers. We have the epiglottis, and it's important to specify suprahyoid versus infrahyoid, paired epiglottic folds, paired arytenoids, and paired false vocal cords. Now, this is a favorite image. I'm going to show you some MR because we're a very heavily MR shop. This is the axial image. We are above the hyoid bone, and this is the Mercedes-Benz sign, or the sign where you see the free edge of the epiglottis, the glossomediaepiglottic fold to the base of the tongue, and the vallecula here as the parts of the mucosal surface that a tumor may spread to. But the good news is most tumors arising from the free edge or the suprahyoid epiglottis are T1 and T2 tumors and are very amenable to very conservative surgical therapy or radiation. Okay, coming down a little lower, now we are below the hyoid bone. We're at the very bottom of the petiole of the epiglottis. We're getting into the aryepiglottic folds. You can see the paraglottic fat. We have the laryngeal airway and the hypopharyngeal airway. And again, the laryngeal airway, the aryepiglottic folds, and the piriform sinuses here. And then on the coronal view, again, as we nicely saw, this is fat. Anywhere you see fat, you're in the supraglottic larynx. So that's critical. You're in the supraglottic larynx. So don't panic. Pull up your image. If you see fat, you're in the supraglottic larynx. This is the laryngeal ventricle. The laryngeal ventricle separates the supraglottic larynx from the glottis. It separates the false vocal cord, as you see here, from the true vocal cord, which is all muscle. And then the axial views, we saw this before. We have the arytenoid, which is part of the supraglottic larynx, giving off the vocal ligament that inserts on the inner lamina of the thyroid cartilage and allows us to support the thyroarytenoid muscle or the true vocal cord. Here is the muscle of the cords, the arytenoids, part of the supraglottic larynx, the anterior commissure, where the vocal cords insert, and then the posterior commissure, best seen in the interarytenoid area. That we're looking at here. And again, a nice coronal view. Anywhere you see fat, you're in the supraglottic larynx. You've got to remember that paraglottic gutter here, very important to look at, as we heard. And again, a nice correlating pathologic specimen showing the cartilage, the areolar fat of the paraglottic space, the laryngeal ventricle, the supraglottic larynx, all fat here, loose areolar, and then the thyroarytenoid muscle, or your glottis. This is down to the subglottis now. So the subglottis has a complete ring of the cricoid cartilage. The mucosa should be imperceptible. I don't want anybody to get fooled by this T1 weighted MR. This is chemical shift artifact. And if you're not sure, you can swap your phase and your frequency and it'll go away. And then just below the cricoid cartilage, you're gonna have the trachea. The subglottis begins 1 centimeter below the apex of the laryngeal ventricle, and again, ends at the lower margin of the cricoid cartilage. So now we're gonna move to image analysis. And this is really important. I don't want people, we're gonna go over a little bit of staging. We're here really to look at the T of the tumor. But I think the real job of the radiologist is in advanced cancers, T3 tumors and T4 tumors. Submucosal spread is usually a T3 tumor. Transglottic spread can be a high-grade T2 tumor, but often it's a T3 disease. And cartilage invasion and extralaryngeal spread are T4 disease. And remember, the goal of treating laryngeal cancer is threefold. Maintain function, so let's maintain speech, Let's maintain swallowing. And of course, cosmesis is always something that's very important when you're taking care of head and neck cancer. I want to remind people about the lymphatic drainage. So the lymphatic drainage, the supraglottis has abundant lymphatic drainage. So does the piriform sinus. So if you're given an exam and you're told the patient has laryngeal cancer and you see nodal disease, you probably got a supraglottic cancer at upfront diagnosis. This is at presentation. The glottis has sparse lymphatics, so it's very unusual for a true vocal cord tumor, a glottic tumor, to present with adenopathy. And the subglottis has intermediate lymphatic drainage, but only 1% to 2% of all laryngeal cancers are subglottic in origin. I say when you see a mass in the subglottis, look up. It's probably transglottic spread from a supraglottic or a glottic tumor into the subglottic region rather than a primary tumor. So staging of supraglottic cancer, let's really nut it down to simplicity. So T1 is one subsite, an area epiglottic fold, the suprahyoid epiglottis, the false vocal cord. T2 is more than one site of the supraglottic larynx, or there may also be involvement of the mucosal surface on the oropharynx, piriform sinus, or the other parts of the larynx. When you have T3 disease, the tumor is limited into the confines of the laryngeal network of the larynx, the cartilaginous network, and you have vocal cord fixation or spread to the preepiglottic space or paraglottic space, or minor cartilage invasion, and T4 disease is major cartilage invasion and extralaryngeal spread. So all of these things here, T1, T2, T3, right down to vocal cord fixation, is the job of the endoscopist. They look at the mucosa. They look for cord fixation. They see the mucosa of the lower oropharynx. This is always good to look. We want to include, but you're not going to miss something major there that your clinical colleague isn't going to see. What is important is the preepiglottic space and the paraglottic space that our clinical colleagues cannot see or palpate. Minor cartilage invasion, I think that's pretty hard for us to see sometimes. And then the T4 disease, major cartilage invasion and extralaryngeal spread into the soft tissues of the neck, into the carotid space, into the prevertebral musculature. So surgical candidacy, if you've got a supraglottic tumor, it's usually below the hyoepiglottic ligament on the infrahyoid epiglottis or aryepiglottic folds, and it invades the preepiglottic space, you are going to have a supraglottic laryngectomy if you're a surgical candidate, which means you'll preserve your speech. You will need to go through a lot of rehabilitative therapy for swallowing. If you've got invasion of the paraglottic space, and it's transglottic, if you're lucky, you'll end up with a partial laryngectomy and you can spare the other cord and have good phonation and swallowing, but you may end up with a total laryngectomy if you're a surgical candidate and that's what's chosen. If you have major cartilage invasion, you are going to have a total laryngectomy. That's just how it is. Same thing with extralaryngeal spread. And if there's prevertebral muscle invasion or spread into the carotid space or encasement of the carotid artery, you are not a surgical candidate because you can't get surgical margins. I have rarely seen a case of laryngeal cancer go to the prevertebral muscles. I have rarely seen a case of a cancer of the larynx going to the carotid space. However, I have seen the piriform sinus fixed to the prevertebral muscle, and I have seen it grown into the carotid space. So you'll hear more about the piriform sinus coming up. So let's look at that preepiglottic space. This is really most abundant and very important for supraglottic tumors. Free edge of the epiglottis, infrahyoid epiglottis or petiole, all the exquisite fat in the preepiglottic space. Hyoepiglottic ligament, so remember above, these are very usually T1 and T2 tumors, below T3, and crisscrossing lymphatic system, so a much higher likelihood of nodal metastases. In the axial view, this is your hyoid bone. You will see the boomerang shape of the normal preepiglottic space with the epiglottis. You'll see the upper area epiglottic folds and the piriform sinus, and this is the very bottom of the petiole of the epiglottis. You have a little preepiglottic space. At this point, most of this is going to turn out to be paraglottic space in the supraglottic larynx. Now, this is the thyroglottic ligament, and at the hyoid bone and above, it's very hard to find the paraglottic space. Once you're below the hyoid, most of the fat is paraglottic space. This ligament here separates the preepiglottic space from the paraglottic space. There's not a lot published on in the imaging literature. I have one paper, but there's a lot in the pathology literature, and you can see the normal fat here. And then the horseshoe. So now let's look at some cases. This is a patient. So first of all, this was missed radiologically. I love to show misses. This was just completely missed. This is not a crisis. You can see the horseshoe lesion involving the petiole of the epiglottis, the bilateral area epiglottic folds. There may be even a little edema here around the piriform sinus. This is the superior saccule, the laryngeal ventricle, in the supraglottic submucosal space, but you can see nice clean fat, preepiglottic and paraglottic, and this is a contained tumor. Again, a very nice coronal view showing you the fat of the supraglottic larynx and the clean paraglottic spaces. In contrast, this is a patient. Here is your hyoid bone. This is coming from the infrahyoid epiglottis all the way up to the hyoid bone, and we can see all of that fat is replaced with neoplasm. There's no clean fat anymore. Here is your pathologic specimen showing all of the preepiglottic fat replaced by tumor, but remember what I told you. Bilateral nodal disease. So once you spread into that preepiglottic space, those crisscrossing lymphatics make you at much higher risk of having bilateral nodal disease, which portends a 50% reduction in long-term survival. Here is another horseshoe supraglottic cancer. So you'll see the tumor here on T1 weighted imaging. You'll see that on post-contrast imaging, the tumor enhances, but it enhances to a lesser degree than normal mucosa. On T2 weighted imaging, we see the tumor and the bright signal of the normal mucosa. And if you become more and more T2 weighted, you see the cellular nature of the neoplasm and the adjacent edema in the mucosa. This is the normal clean fat that you'll see here in the anterior preepiglottic space. This is replacement of the fat in the left preepiglottic space, your thyroglottic ligament, and here you move on. This is a different patient with transglottic spread of a supraglottic tumor. So we have a coronal image here. You can see the normal fat in the paraglottic gutter. We can see the laryngeal ventricle separating the supraglottic larynx from the thyroarytenoid muscle or the glottis. And if we look closely here, normal fat, replaced fat. So this is transglottic spread in the paraglottic gutter. And if you look at a corresponding pathology specimen, you'll see the tumor on the mucosal surface of the false chord. You'll see a little bit of tumor crossing the laryngeal ventricle and on the mucosal surface of the true vocal cord. But all of this is tumor in the paraglottic space here. So this is transglottic spread. This is the thyroid cartilage. So mucosal spread and paraglottic spread, transglottic. This is another supraglottic tumor, big tumor involving the area epiglottic fold. You can see the abnormal tumor going transglottically along the mucosal surface to the true vocal cord. You can see tumor, here's the normal paraglottic fat, tumor going down the paraglottic gutter from the supraglottis to the glottis here. And don't stop looking, now you're at the subglottis because you can see the cricoid cartilage. Here is the tumor on the mucosal surface. Here is tumor in the paraglottic gutter, and here is tumor all the way down into the subglottis. And don't stop looking. Well, I don't know if that'll go back. I just wanted to show you got to pay attention to these cartilages as you'll start to see invasion. We know probably that the cord is fixed because the arytenoid that gives rise to the vocal ligament that supports the true vocal cord is sclerotic and encased. So the cord is probably fixed, so you know really if the cartilage is invaded here, you're at T4 disease. Here is a piriform sinus tumor. I'm only showing you this because not uncommonly, there'll be a mass at the supraglottic larynx level and our clinical colleagues can't get the scope into the piriform sinus to figure out whether it's a piriform sinus primary or an area epiglottic fold. This case is easy. You can get your scope in here. There's circumferential disease, tumor coming down, and you've got to follow it all the way down to the apex of the piriform sinus. But this is the real reason I'm showing you. You're just below the hyoid bone here. This was read as a supraglottic tumor. It's not a supraglottic tumor. This is actually a piriform sinus tumor. We have have our thyroglottic ligament. This is the preepiglottic fat. This is tumor in the paraglottic fat, invading the thyroid cartilage, and in fact, a lot of these piriform sinus tumors wrap around the thyroid cartilage and go directly into the strap musculature. So very important. These are also the tumors that may become fixed to the prevertebral musculature. There's your thyroglottic ligament here and the normal fat on the opposite side. This is a different piriform sinus tumor, second versed, same as the first I just showed you. Again, you can see abnormal thyroid cartilage, tumor around the cornea of the cartilage, extension into the strap muscles here, and again, the nodal disease, which is very common in piriform sinus tumors. So, staging of primary glottic cancer. T1 tumors are limited to the vocal cord or cords or to the commissure. It could be an anterior commissure, rarely a posterior commissure. T2 tumors have supraglottic or subglottic spread with impaired cord function. And once you get down to having a fixed vocal cord, paraglottic space spread, or minor cartilage invasion, you're at a T3 tumor, and a T4 tumor is cartilage invasion and extralaryngeal spread. Honestly, these are the most important concerns of our clinical colleagues, as is the paraglottic space and minor cartilage invasion. Here's a true vocal cord tumor. It's protruding across the anterior commissure, but the contralateral cord is preserved, so this is a good candidate for a vertical laryngectomy. You can see the neoplasm. Here's the tumor here, and the opposite cord had a small polyp on it. And occasionally when we're looking at these glottic tumors, the surgeon will want to know definitively whether the tumor is above the cricoid cartilage. We do a lot of very sophisticated partial laryngectomies, and this is occasionally when I'll turn on my virtual laryngoscopy and show that the tumor is indeed above the cricoid cartilage. Different surgical procedure if it's not. Here is the sagittal view, and what you'll see here is a tumor crossing the anterior commissure, right, at the level here, and you'll see it's involving the contralateral 1/3 of the opposite cord. That's about as far as it can go and still have a vertical laryngectomy. If you get to the back third of the cord, the back 2/3 of the cord, normally they cannot preserve speech. So it's very important to denote if the opposite cord's involved. You can see the nice clean paraglottic fat here, and this patient had a vertical laryngectomy. Here's two different patients with subglottic extension. Here's a right true vocal cord tumor going down into the subglottis. We've got normal fat in our thyroid and cricoid cartilages, and a different patient with a left true vocal cord tumor. We see that the normal fat of the arytenoid, this is the normal side, is replaced. We know this cord is probably fixed, though the surgeon will confirm that. And here we see the subglottic extension. So fixed cord, negative cartilages, T3 tumor. This is a very sad case. It's a relatively young person, and you'll see this massive tumor involving both cords. It goes right through the anterior commissure into the soft tissues of the neck, the strap musculature, and you can see these metastatic Delphian nodes as well as bilateral nodal metastases. Again, this is a very aggressive presentation of laryngeal cancer. This one happens to be HPV positive, of course resulted in a total laryngectomy followed by chemoradiation. But this is an unusual presentation. This is a 21-year-old that had papillomatosis. You'll see the right cord here. There's some abnormality. There's a tiny bit of involvement of the anterior commissure, and there's involvement of the mucosa in the subglottis, right? Every time we see cricoid, we know we're in the subglottis. Been imaged and followed for 3 years. I called them up when I saw this scan, and I called them up because I saw this. This was a new, small, mildly necrotic Delphian lymph node, and they said, Laurie, we've biopsied it 3 times. I said, well, go back now and do your 4th, and this is a 21-year-old that ended up with a total laryngectomy for invasive squamous cell carcinoma, another HPV case. I'm going to show you 2 slides of the subglottis. Why? Because only 1 to 2% of all primary laryngeal cancers come from your subglottis. If you see a mass in the subglottis, look up. It's probably a supraglottic tumor or a glottic tumor spreading down. So here is an example of a primary mucosal tumor here. This is chemical shift artifact. Don't mistake it for a neoplasm. You can swap your phase and frequency. And this is a different patient that presents, and you'll see this tumor, they came in as an airway emergency, and this thing is growing right from the subglottis through the tissues into the soft tissues of the neck. I see 2 primary subglottic cancers a year. One normally looks pretty indolent like the first case, and the other one is usually an airway emergency. But again, the key is if you see something in the subglottis, look up, because it's usually spread from above. So T3 and T4 squamous cell cancers of the larynx, these are what we call advanced tumors, and we are looking for speech-conserving therapy, right? Speech-conserving, swallowing, cosmesis. So we're trying to do partial laryngectomies, and we're trying to do organ-preserving definitive chemoradiation when the patient is a candidate. The major factors allowing us to determine whether these advanced tumors are going to have some type of organ preservation is threefold. Bulk of the tumor, usually determined by the clinician. Sometimes they'll do metabolic tumor volume on a PET. We don't do that at our institution. Functional larynx. What is the function of the larynx? Again, that is the job of the endoscopist. And the last job is cartilage invasion and extralaryngeal spread. That is our job, and these are the main factors that are going to let us know. So let us go on to cartilage invasion. Remember, not only does cartilage invasion impact treatment selection, it also has different prognostic indications for local control and overall survival, both worse with the presence of major cartilage invasion. So it's not just the treatment selection, it's the prognosis and how the patient is counseled. So we're going to look briefly at the development of the thyroid cartilage, then we're going to look at CT and MR images of anatomic variations of mineralization. We're going to look at cartilage invasion and just again highlight a few of the limitations of imaging at looking at cartilage invasion. So cartilage invasion changes treatment. Major cartilage invasion, which is destruction of the cartilage, the lamina, marrow invasion, and spread into the strap muscles, any of those things, results in a total laryngectomy, and chemoradiation is contraindicated. There's a high likelihood of getting cartilage necrosis. I don't know if any of you have seen radiation necrosis of the cartilages. It's got a reasonable mortality rate, just horrible. Fistula is just a devastating thing. This is what early radiation necrosis looks like, just a little edema in the tissues, but you're starting to see air in the subcutaneous tissues where it doesn't belong. In addition, if you do chemoradiation with major cartilage invasion, other than the complications, decreased local control and inferior survival rates. So surgery really is the treatment of choice in that instance. If you don't have cartilage invasion, or you have minor cartilage invasion, which is just erosion of the inner lamina of the cortex of that cartilage and nothing else, then you can get chemoradiation. And the good news is, if you fail chemoradiation, then you can go on to your salvage laryngectomy. And with minor cartilage invasion, there's no significant difference in rates of survival as long as the larynx is functional. So let's look at mineralization of the thyroid cartilage. I really enjoyed, going through the literature on this. So ossification of your thyroid cartilage begins posteriorly and inferiorly along the lamina. And it progresses superiorly and anteriorly as we age, and many of us sitting in the room are still ossifying. There's ossification of the anterior cartilages going well into your 60s. And also, there's a wide spectrum of calcification. Some people have predominantly sclerotic cartilages. Some will have predominantly fat in their marrow. Some will never ossify the anterior portion of their cartilage, but it's important to know that there is a spectrum. Here's a patient starting inferiorly. You're at the cricoid and working our way superiorly. You'll see the cortices, the marrow, and as we get into the upper thyroid cartilage here, you'll see it has not yet ossified. So this is a not unexpected thing, and then there's the anterior cartilage is not mineralized.
2 minutes left. 2 minutes left.
Okay. Non-ossified cartilage, I got started late. Okay. My clock says 6 minutes, okay. Non-ossified cartilage, so you'll see fat in the cartilage here, fat in the cartilage here, so that's important. It's also important to remember where the anterior commissure inserts, there's a lot of tugging of the cords on the cartilage, so the cartilage becomes ossified, as you'll see here. And then you'll see variations in cartilage calcification. So look at patient 1, upper, mid, lower, a different patient with a lot more fat in their cartilage, but notice the symmetry. Patient 3, here's their pattern. Patient 4's got a lot more globular calcification. Variations in cartilage mineralization. So very importantly, 90% have right-left lamina symmetry. So when in doubt, check it out. You should look very symmetric when you're looking at your cartilages. Asymmetric lamina, so this is focal ossification in non-ossified cartilage. This is an example of the 5 to 10% asymmetry. And some people get focal fat in the ossified cartilage. In that I am not going to be able to finish, I will just show you some examples. This is minor cartilage invasion in the inner cortex of the anterior commissure, major cartilage invasion of the cortices, the outer cortices, the marrow, and here you'll see through and through invasion, involvement of the strap muscles. And this is one that has gone through the anterior commissure, is actually eroding from the outside in. And these are examples of extension through the notch of the thyroid cartilage into the extralaryngeal tissues. Again, another example of cartilage invasion here and involvement of the strap muscles, very important to look for that. And MRI just showing you normal fat, high signal intensity, and the normal suppressed appearance of the marrow. In that, looks like I'm going to be axed off the stage. I'm sorry I can't finish my last 7 slides, but I'll make sure the slides are available to you so that you can have it. Thank you very much.